All right, good morning, everyone, and welcome once again to another install of the weekly New Brunswick Heart Centre CV rounds. This morning, it's my pleasure to introduce Sue Morris. Sue Morris has been a clinical nurse educator with the New Brunswick Heart Centre for as long as I can remember, and probably longer. And she really wanted to take the opportunity to present on a particular topic, which is resuscitation guidelines. For those of you who know, and many of you who don't know, the BLS and ACLS resuscitation guidelines are constantly being updated. And there was a recent update that came out in October on the part of the International Liaison Committee on Resuscitation, or the ILCOR, that really kind of changed a lot of the resuscitation paradigms. And I thought it was a good opportunity, or at least Sue thought it was a good opportunity, to bring this up and educate us to this effect. And I thought it was great because, let's be honest, my ACLS is still from when I first did it, which was probably 1975. So without further ado, I'd like to present Sue, and take it away.
Awesome. Thanks, Ansar. So this is going to be a far from comprehensive review. It will focus on the adult, and it will really look at the things that affect our practice, mostly in the Heart Center. So who is ILCOR and what is their role? So ILCOR is a committee of international researchers who are made up of the American Heart Association, the Australian New Zealand group, Heart and Stroke Canada, which is who I sit with, European Resuscitation Council, we've got the Latin American group, Asia, and Africa. So every 5 years, the guidelines are released, and so researchers come together, look at what the data is. And in 2015, they decided that, hey, maybe 5 years is too long. So they offer a focused update, but every 5 years, there is a significant review of all of the science. So when we look at the level and the quality of the evidence, it goes from a class 1 recommendation, which is strong, down to a class 3, which is an orange, showing no benefit, or red, harm. And then when we look at the level of evidence, we go from level A, which is randomized controlled trials and meta-analysis, all the way down to expert opinion. And so when we look at these guidelines for 2020, 6 of the 491, or 1.2%, have a level 1A recommendation. So as you can see, resuscitation science is not real robust in evidence. So a lot of it is expert consensus. So for 2020, let's start with the tachycardias and the bradycardias. Tachycardia really hasn't seen much change. So management is still looking, is the patient stable or unstable? Stable patient, they suggest vagal maneuvers and rate lowering or rate altering medications. Adenosine is a top choice for regular tachycardias, but we can also use adenosine to help us diagnose rapid AFib when it's too fast to discern. For the unstable tachycardia, we continue with synchronized cardioversion for that patient population. And then when we look at bradycardias, there has been a change, not a whole lot of explanation in the literature about why these have happened. So when you look at atropine, our 2015 recommendation was 0.5 milligrams, and 2020 is now suggesting we use a full milligram. And I think that's probably related to lots of anecdotal discussion about the paradoxical bradycardia effect that happen when we give lower doses of atropine. So I do know that Dr. Toll was quite pleased to see this change. And the second change is they've changed the dose range for dopamine. So the original was 2 to 20, and now it's 5 to 20 mics per kilo per minute when we don't have an immediate transvenous pacemaker available. And I think that's given to the fact that you don't get much of a positive chronotropic effect at low dose dopamine. So not much excitement there. There is a new link in the chain of survival, and it is recovery for both in hospital and out of hospital. And basically what they want us to look at and focus is to educate the patient and their family that the road to recovery can be very long following cardiac arrest. So when we look at ILCOR has always maintained the philosophy that we need to be safe. As providers, we need to be safe. And so this is particularly true in the era of COVID-19. And so the ILCOR is suggesting that CPR is an aerosol generating medical procedure, and that we should be wearing full PPE, including an N95 mask. So my question for you to reflect on is, should we consider all patients in-house COVID positive until proven otherwise? I know that our partners in the emergency room are treating all code blues as COVID positive. They have a little bit different spin on it. Their person is coming in, they haven't had an assessment. So anyway, that's just sort of a self-reflective question for you to think about. Let's start with a little case study here. So let's meet Joe. Joe's a rather robust gentleman. He's 49 years old. He's got type 2 diabetes. He's hypertensive. He's got morbid obesity. And he has suffered a cardiac arrest in New Brunswick, rural New Brunswick. And when we look at our ambulance New Brunswick response times, we see that urban, 9 minutes or less, but rural is 22 minutes or less. And that can be a big deal on outcome. So there is a physician at Sunnybrook Hospital, Dr. Sheldon Chessex, who has done a lot of research in drone therapy and drone therapy as it relates to delivery of AEDs. So I'm not saying that tomorrow you're going to look out your window and see a drone flying by with an AED, but in his research, he has been able to demonstrate that he's able to reduce rural response times by almost 10 minutes with the use of AED drones. So when we look at the Canadian climate, there are challenges related to that, fog and drones. So St. John may not have a drone that is useful, but certainly something to look at. So when we look at feedback devices and quality indicators of offering CPR, there was a recent randomized controlled trial that showed an increase in survival by 25% when we used a feedback device. So a feedback device tells us whether we're going the right depth, the right rate, and if we're getting full chest recoil. So the recommendations for CPR really haven't changed. 2 inches in depth, a rate of 100 to 120 compressions per minute. And really, we should be looking at, are we getting full chest recoil? Should we be using audiovisual feedbacks? The evidence is not robust, but there's also the discussion about the physiological parameters, such as diastolic blood pressure and end tidal CO2. So our colleagues in the emergency department are really quite good at using exhaled carbon dioxide as an indicator of quality CPR. So when we do have an intubated patient and we connect them to end tidal CO2, we're looking for a numeric value of greater than 10. And the 2020 guidelines suggest that we should be focusing and aiming for a numeric value of 20. When we look at diastolic blood pressure, the recommendation is trying to get 20 millimeters of mercury or more during compression. Now, all of this data is on animals. There is no human data. So it's difficult. Not many patients have arterial lines, and you have to have an intubated patient to measure and exhaled carbon dioxide. So the two parameters that we have to measure quality of CPR really are not for everybody, and that makes it difficult. Defibrillation. Early public access defibrillation has really been pushed, especially in New Brunswick. And biphasic energy is still the proven recommendation. And we still go with the single shock protocol as opposed to stack shocks. Now, that's not to say in a cath lab or in a coronary care where a physician is standing there, we witness a cardiac arrest, that you can't offer stack shocks, but single shock is intended to minimize the time off of the chest. And as a recorder in a code blue, we have been educating people to give an auditory clue. 10 minutes or 10 seconds off the chest, 20 seconds off the chest, so that everybody in the room has an idea of how long CPR has not been provided. So defibrillation, really the recommendations are single shock, use biphasic, and if in doubt, if you're coming across your defibrillator and you've never used it before, go to the highest level of energy. And in the 2015 guidelines, they offered a whole lot of ranges for cardioversion. Those have been taken away, and basically the disclaimer is follow the manufacturer's recommendations. Pad placement. So anterior, posterior is what I was educated with when I first became a nurse. We then moved to the anterior lateral, but they're saying both pad placements are acceptable as long as the diameter of your pad or paddle is at least 8 centimeters in an adult. So back to Joe. Joe arrives at the regional hospital. He's in full arrest. He's received 4 shocks from his AED. Cardiology are consulted, and here's our favorite boy. He comes into the emergency department and he says, "Hey, we got a large guy here. Let's try double or dual sequential shocks. Use the maximum joules. How much epi has he received? And will he fit in the Lucas?" So, of course, all those orders have been barked out. So what do we attempt first? We try a dual sequential defibrillation. And so here is one picture of pad placement, although I would argue that this pad is probably closer to the kidney than it is the heart. But we have the blue pads that are in the anterolateral position, and then we have the red pads that are in the anterior posterior position. So there is some anecdotal discussion in the literature that this has been tried on morbidly obese patients. And so we did attempt it on Joe, and it was unsuccessful. So the guidelines looked at it this time, and they're not prepared to make a statement. The usefulness has not been established, but that's not to say it's discouraged, but routine use has not been established as useful. So some other electrical adjuncts that they looked at in these guidelines were precordial thump. So I see Dr. Marr is online. I've seen Dr. Marr give a precordial thump in his career. Haven't seen it lately, but certainly back in the 80s. So the routine use is is not recommended, but we should be using this or could be using it in a witness monitored arrest when a defibrillator is not readily available. In 2010, there was a discussion that pacing was kind of futile for asystolic patients. And we need to remember that that does not apply to the post-op cardiac surgery population. We would immediately pace them for asystole. So no benefit. Epinephrine, this is probably more the most controversial part of these guidelines. So here is the latest algorithm. So if you go down the left column, you'll see this is shockable rhythms. And so we recognize VT or VF, we deliver a shock and start CPR. Epinephrine is now recommended after our second shock. When we look at the non-shockable algorithm, epinephrine is really moved up in its position, and they're suggesting that we give epi as soon as possible in the non-shockable arrest. So published in 2018, this is called the Paramedic 2 trial. And patients were either randomized to placebo or epinephrine. And it's about 8,000 patients. And the end result was survival was more prominent in the epinephrine group. Great, if you're looking at survival. However, the patients who did survive in that epi group, they had much more severe neurological impairment. And so this has created a bit of a controversy about epinephrine. So what are the recommendations? That we use it in a cardiac arrest, that it be given 1 milligram every 3 to 5 minutes. And the new guidelines suggest using 4 minutes. So that between shocks, every second shock, after your shock, you would administer epinephrine. When we look at vasopressin and epinephrine, there really is no difference. And so what they said was vasopressin is much more difficult or non-user friendly. So in 2015, they suggested that we just go with epinephrine for ease of use, but that may differ in the cardiac surgery population. And high dose epi is not recommended. So in light of this trial, I kind of ask you another reflective question. Should epinephrine be a class 1 level B recommendation? I don't know. I found that a very interesting trial to read. So non-vasopressor medications, so our antiarrhythmics. So in 2018, there was a review that demonstrated both lidocaine and amiodarone showed an improvement to hospital admission for out-of-hospital arrest, but that did not equate to overall improved survival at discharge. So amio or lidocaine should be considered after you have offered defibrillation. There, in the literature for these guidelines, there was some discussion about 2 randomized control trials, both from one single center, that talked about steroids. And I know this has been my entire career has been a yes, try it, no, try it. The last little while has really been no, there's no use. However, in these 2 trials from this one single center, there was some benefit when steroids were given to the patient. However, when you read the study, they were given in combination with epinephrine. So certainly some work is required there. There is no routine recommendation for the use of calcium, sodium bicarbonate, or magnesium in a routine code. So what about manual compression devices? Lucas, we have recently purchased a couple of these for the St. John Regional Hospital. And so the routine use of these is not recommended, and really the routine use is related to the fact that it takes a bit of time to get these on the patient. And so we need to be cognizant of how long we are spending off of the chest applying these devices, but they're certainly really good. We purchased the first one for our ECMO program. And so here's Joe. He has fit into the device, no problem. Central obesity is not the problem. It is women with robust breast tissue, it gets in the way. But central obesity is not an excluding factor, and there is no true weight restriction. It's if you can fit in, and so Joe fit in. What are they saying about point of care ultrasound? That it's certainly something that you can use as a diagnostic tool, being cognizant of how long you are off the chest. And so back to Joe, we identified that he had a very dilated right ventricle. The team was suspicious that he had a massive PE, even though he was in a shockable rhythm, because most PE patients would present in PEA. So it was decided he had a reversible cause of this cardiac arrest. So here comes our esteemed Dr. White, and does he smell an ECMO opportunity? Absolutely. So what's the literature tell us about eCPR and ECMO? That there certainly is a role for it in reversible causes of cardiac arrest. So eCPR has gotten about 8 pages dedicated to it in the ACLS manual. I don't think we're quite ready for what we see in France, which is, here we are in public transportation. We're doing ECMO underground. I really hope we're never here in Canada doing this, but that's my personal opinion. So Joe was given systemic fibrinolytic therapy. He had his Lucas for 17 minutes, and he had return of spontaneous circulation, but he remained comatose. So we need to cool everybody who is comatose. In 2013, there was a clinical trial published that put 36-degree patients and 33-degree patients head to head, and it showed no difference in neurological outcome. However, when you look deeper into that study, 72 to 74% of that both of those arms had bystander CPR, which puts them at an advantage neurologically. So what we have decided at the New Brunswick Heart Centre is to really not change our practice, but to go with 33, and if we have problems, then go to 36 degrees. This is the algorithm for return of spontaneous circulation. It gives us a bundle of care for targeted temperature management. So saturation, 92 to 98% for all patients. There is a diagram for neurological prognostication, and the thing to remember is we do not start prognosticating until the patient has reached 72 hours post normothermia. So here's Joe following 12 weeks of cardiopulmonary rehab. The real he is shining through. And so a couple of other things, electrolyte abnormalities. We should be giving calcium for anybody who's a hyperkalemic arrest. surprising, not surprising, that administration of IV potassium can cause harm. Funny. Opioid overdose, significant discussion in the guidelines. So what we see on many walls is AEDs in cabinets, Narcan in cabinets. So when I discuss this with the nurses, they think there should be a third cabinet, and this is what it would look like. Maybe out of reach of patients, but yeah. Pregnancy, divert the uterus so that there is not great vessel compression. And so take home messages, go hard and go fast, but not too hard and not too fast. Early defibrillation for VT and VF. And so the benchmark to reach for in-hospital cardiac arrest is time of first defibrillation should be less than 3 minutes. Hence the reason why we have a lot of AEDs in our hospital. Epi should be given to the patient after the second shock in VT and VF, but earlier in the PEAA systole arrest. There's no role for vasopressor and inotrope infusions until the patient has had return of spontaneous circulation, and consider cooling in everyone that remains comatose after ROS. And that's it.
That's great. Thank you, Sue.
No problem.
Excellent. Great overview. First thing, it's nice to know that Joe is actually African-American. That's excellent. Secondly, it's interesting because, you know, when you look at this, obviously there are subtle changes that kind of take place from iteration to iteration. But in your collaboration with the Code Blue team here at the hospital, what is your sense of their take on developing truly an expert team? That, because I mean, at the end of the day, I think what happens a lot of the time is you have people who are assigned to the Code Blue pager, they show up, but there's never really a consistent team that runs these codes and achieves the same outcomes. Is there any data on sort of inconsistent team approach? And then secondly, would there be a value? I mean, obviously the post-cardiac patient's a little bit different. We had that CALS presentation last year, but nevertheless, I think we still see a lot of patients across the hospital, whether they're coming through emerge, et cetera, who are out of hospital arrest, and there's still such incredible variability in how it is that they're managed. What does Heart and Stroke try to do, and what are your thoughts on really just sort of consistent Code Blue approaches?
So funny you should say that. So Andrew, my co-partner in crime, for Andrew and I are co-chairs of the Zone 2 Code Blue Committee. And so we have been looking at and have put forth a proposal to senior executive to develop a STIM program, because we see such a complex, convoluted, unorganized approach to team Code Blues, that we really feel that there needs to be some simulation, especially with regard to personal protective equipment. And so that's kind of our first approach. Second of all, ILCOR has really put forward quite a robust education component to ACLS. They've really focused on educating as a team, and they've even implemented the thoughts of a CPR coach during a resuscitation who is dedicated to saying, yes, go harder, go faster, no, slow down. Your end tidal CO2 has just risen, so let's do a pulse check. And so they have done a good job. We just need to be a little more organized in our facilities, I think.
And I think to address your question earlier, and somebody made a comment to this effect just now in the chat room, but I think with COVID, or at least the threat of COVID in our community, yeah, you know, we're just seeing it in the OR, for example, just the sheer act of, you know, donning and doffing and all of that. I can't imagine that there's incredible time lost in the process. Like, if there's got to be some way to initiate, I mean, obviously, it's different a little bit in hospital. Somebody's been sitting in hospital for, you know, a few days, and you kind of have a sense, and they may have been, may or not have been tested. They've definitely been screened, this,
Yeah.
that, and the other. But somebody who's coming in from, you know, from the field, so to speak, or being treated in the field, you almost have really no choice but to kind of treat them as if they're positive, and that whole process has to take time.
Yeah, so that's kind of been the New Brunswick approach is in-hospital patients have been screened. So unless they are on droplet precautions, we're not donning full PPE. However, in the emergency room, in the OR, and in outpatient areas, we should be looking at wearing full PPE where patients have not been screened appropriately or have had time to be screened.
Yeah, absolutely. Well, thank you so much for summarizing that, and I'm sorry that we had to kind of rush a little bit at the end, but
That's quite all right.
it was excellent, and it kind of touched on a lot of, you know, interesting topics, including eCPR and the role of the Lucas, et cetera, et cetera. So Sue, thanks so much. And next week, our esteemed colleague, Dr. Rob Stevenson, who was made reference to in this presentation, will speak on the subject of smoking and cannabis use. And I kind of titled it, you know, is this the next epidemic? I think especially with COVID and people in Orange, there's a lot of cannabis use. So it'll be interesting to see what his take on this is. So with that,
Yeah.
thank you so much, and have a great day, and we'll see you all next week.
Awesome. Thanks.